Thank you, Dr. Patel. And I think I'm a little bit more comfortable talking about immunotherapy than neck dissection, so I'm glad we got that straightened out. I'm going to be speaking about the results of a phase 3 clinical trial called Checkmate 067, which was an efficacy comparison of nivolumab alone, ipilimumab alone, and the combination of the two in patients with metastatic melanoma. In background, I think many of us are aware that there are several positive and negative checkpoints that control the immune response. CTLA-4 and PD-1 are two such negative checkpoints. They represent distinct and complementary pathways that negative regulate tumor immunity, and that provides a rationale for simultaneous blockade of both targets. Both of them have been shown to impact overall survival in melanoma. Actually, it was just 5 years ago that my colleague behind me, Dr. Steve O'Day, stood on the same podium introducing ipilimumab as the first medicine ever to improve overall survival in melanoma. Nivolumab was just shown to improve overall survival, the PD-1 blocking antibody, and we had conducted both phase 1 and phase 2 studies of this combination, which showed an unexpectedly high response rate of about 53% in the phase 1, 59% in the phase 2, with 2-year overall survival rates ranging from 79 to 82% depending on dose. So the current study is the first phase 3 to look at this question. This is the design of Checkmate 067. 945 patients with unresectable stage 3 or 4 melanoma were randomized 1:1:1 to either the combination of nivolumab alone, 1 milligram per kilogram, ipilimumab alone at the standard dose, together 4 times every 3 weeks, followed by nivolumab alone, or nivolumab alone with a ipilimumab matched placebo, or ipilimumab alone with a nivolumab matched placebo. These groups were stratified by PD-L1 expression, which I'll get into, BRAF status, and M stage. The co-primary endpoint that I'll be reporting on in the plenary is the progression-free survival. Overall survival, just in case anybody is going to ask, is not expected to be reported until 22 months of follow-up, so we're quite a ways away from that. Secondary endpoints include response rate, the influence of PD-L1 expression, and safety. So this is the co-primary endpoint data, which is progression-free survival. And if you look at the 3 groups, the nivolumab plus ipilimumab group had a median progression-free survival of 11.5 months, nivolumab alone 6.9 months, and ipilimumab alone 2.9 months. You'll notice that there are hazard ratios for all 3, so the reduction in the risk of death for the combination versus ipi is 58%. For nivo alone, it's 43%, and there's a separate line for the comparison between the combination and nivolumab alone. That's because that was not a statistical endpoint of the study, but we report that there's a 26% reduction in the risk of progression or death for the use of the combination in comparison with nivolumab alone. When we look at these results stratified by PD-L1 expression measured at greater than or equal to 5%, in the group of patients who have tumors that have more than 5% PD-L1 expression, with the combination, the median PFS is 14 months. With nivo alone, it's the same 14 months and 3.9 months for ipilimumab alone. However, when we look at patients whose tumors have PD-L1 expression less than 5%, the combination yields a median progression-free survival of 11.2 months, nivolumab alone 5.3 months, and ipilimumab alone 2.8 months. When we look at the response rate overall in the intent-to-treat population, it's 57.6% for the combination of nivolumab and ipilimumab, 43.7% for nivolumab alone, and 19% for ipilimumab alone. Importantly, if you look at the duration of response for all 3, it has not been reached with a minimum of 9 months of follow-up, which is very characteristic for any immunotherapy. We also looked at the median change in tumor burden, so how much the middle patient on the waterfall plot had a change in tumor. And so for the combination group, the median burden change was 51.9% decrease. For nivolumab alone, 34.5% decrease. And for ipilimumab alone, 5.9% increase. Importantly for safety, we actually saw no drug-related deaths in the combination group, which I think is a very important point because this trial was conducted at 137 sites globally, and the safety guidelines that were put in place along the way during the development of both ipilimumab and nivolumab clearly were able to handle these side effects, as were investigators in a variety of different venues. So this treatment can be safely applied in a global setting. Importantly, if you look at the treatment-related adverse event rates for the combination, grade 3 and 4 adverse events is usually where we focus. 55%, which is very aligned with the phase 1 and 2 data for the combination. 16% for nivolumab alone. 27.3% for ipilimumab alone. Interestingly, if you look at the patients who had to discontinue treatment because of side effects, which was 36.4% for the combination, that group of patients had almost a 68% response rate, with half of those responses occurring after the patient stopped treatment. So clearly these guidelines for when to stop treatment and how to manage the side effects were very effective in establishing a good risk-benefit profile. So in conclusion, nivolumab alone and nivolumab and ipilimumab significantly improved progression-free and overall survival compared with ipilimumab alone in patients with previously untreated melanoma. The combination resulted in numerically higher progression-free survival and a higher overall response rate versus nivolumab alone. In patients whose tumors have a greater than 5% PD-L1 expression, both nivolumab alone and nivolumab plus ipilimumab combination resulted in a similar prolongation of progression-free survival. The safety profile of the combination was consistent with earlier experience. The majority of adverse events were managed and resolved with the established algorithms. So based upon the available evidence, the combination represents a means to improve outcomes versus nivolumab alone, particularly for patients whose tumors have less than 5% PD-L1 expression. Thank you.